Hello, everybody. Thank you so much for joining us today for our podcast session titled One Swab Ahead, Proactive Screening for Candida auris. I am Dr. Sarah Elliott, and I'm on the Scientific Affairs team at DSORN, and I am joined today by Dr. Lucas Osborne. He is the Director of Microbiology at Keck Medical Center at USC. And today, I'm going to provide just a little bit of background about Candida auris and why it's such a concerning threat before we dive right into our question portion. So, Candida auris really has emerged as one of the most concerning fungal pathogens in recent years, with the first case reported only back in 2009, but since that time, this organism has spread rapidly around the globe. And Candida auris is considered a very concerning healthcare threat for many reasons. This organism spreads easily in healthcare facilities. It is able to colonize and persist on patients as well as environmental surfaces within our healthcare facilities for prolonged periods of time. The organism itself is often multi-drug resistant, which is very concerning. And also this organism has caused outbreaks that are extremely difficult to control. And also, unfortunately, the patients that are most vulnerable to Candida auris are those that are already having serious underlying medical conditions and often also receiving high acuity care. And so one thing to note is that while colonization itself is asymptomatic, patients that are colonized are still considered a risk for several reasons. One is that colonized individuals are themselves an important part of the transmission chain and part of the transmission cycle, and so they are a risk to transmit the organism to other vulnerable patients. And then also, it's understood that colonized patients are also at risk of converting to developing an invasive infection themselves. And these invasive infections can be quite serious, particularly if they develop a bloodstream infection. It's also established that patients that are colonized also remain colonized for extended periods of time. So if this colonization is unrecognized, then unrecognized transmission can occur across different units, across facilities, different care settings, things like that. And so for these reasons, screening for colonization is a really essential component of infection prevention. Effective screening programs can help healthcare teams identify colonized patients earlier, implement appropriate precautions, and as we'll talk about today, even de-escalate these precautions when unnecessary, which is a very important element. Understand transmission within facilities, as well as respond more quickly when cases are discovered. So today, Dr. Osborne and I will discuss just exactly what it takes to successfully implement on-site molecular testing for Candida auris colonization, how laboratory and clinical teams can work together, and then we'll discuss also why advocacy is so important for moving screening from a recognized need to a sustainable part of patient care. So with that, I think we've enlightened the listeners to the importance of Candida auris. So to kick us off, Dr. Osborne, why don't you please introduce yourself a bit more formally and tell us a little bit about your background in the laboratory.
Sure. Thanks for providing a really nice summary and introduction to why we should be talking about C. auris today too. I'm Luke Osborne. I direct the Clinical Microbiology Laboratory at Keck Medical Center of USC, and I'm an assistant professor of clinical pathology at the Keck School of Medicine of USC. And my primary interests are really in molecular testing, and my favorite subsection of microbiology is mycology, which Candida would fall under. So.
Yeah, excellent. That's mycology, obviously very relevant to today's discussion. So from your perspective, and I think also very relevant considering we're sitting here in sunny Southern California, why has Candida auris screening become an important priority for healthcare facilities?
Yeah, I think you touched on it. It's important for a couple different reasons, but first and foremost is patients who are colonized with C. auris are at increased propensity to develop a systemic infection. So hospitals want to keep their patients as safe as possible, and part of doing that is a comprehensive surveillance system because, as you mentioned, a colonized patient also increases the risk for transmission. Even if a patient doesn't develop a clinical infection, if they carry the organism, they could still spread it throughout the environment that they interact with. So sort of a two-headed approach, basically preventing a patient who is colonized from developing infection, or at least identifying those who are at an increased risk, and also keeping our non-colonized patients safe by protecting the environment.
No, I agree. Those are very important elements. So it seems like we agree screening for Candida auris colonization is very important to protect our patients. So can you describe your lab's experience and your institution's experiences with screening for Candida auris colonization? I understand your institution has been screening for a while and perhaps has undergone some evolution over time of these methods and
Yeah, sure. As
strategies.
you're aware, California is really at the forefront of, globally we see an increased prevalence of Candida auris for, at least the last 5 years now as it's really started to ramp up. And particularly in California, we've seen pretty marked increases in Candida auris prevalence. So historically, we used to do a send-out molecular screening approach. Basically, a patient would have a bilateral axilla groin swab in a simple e-swab, and that was sent out to a reference laboratory for a PCR test for surveillance purposes, which provides a result detected, not detected. And so, as you can imagine with a reference laboratory, we don't have control or autonomy over the turnaround time, for example. So it would usually take somewhere between 2 and 4 days to get results back. And that was an issue for our medical center because during that time, patients are basically being isolated, waiting for the results to come back if they meet one of the pre-screening criteria for isolation. So for us, it made sense, as you suggested, to evolve into an in-house testing system, which we had more autonomy, control over, and we could, the ultimate goal was to reduce the turnaround time for our C. auris screening.
So you touched on a few key elements that leads me into my next question. So it sounds like there were a few key drivers, including the perhaps suboptimal time to result and perhaps variable time to result that you're waiting on, that patients are waiting in isolation and on contact precautions, and one, I suppose, would assume the vast majority of which are expected to be negative results, so unnecessarily so. And so can you talk a little bit more about some of the main challenges, perhaps including, but maybe not limited to, this turnaround time that really led your institution to essentially what was your organization trying to solve when you're evaluating changes to the methods and basically the structure of Candida auris screening?
Yeah, sure. And from the patient perspective, first, if you meet those pre-screening criteria and you're in contact isolation, basically you have more limited touch points with your healthcare provider because basically you are isolated from the rest of the general population of the medical center. So that's one important consideration. And the second is on the flip side, the staffing of the medical center itself. It takes a tremendous amount of resources to basically free up that space and dedicate resources to only those contact isolation patients. So it's really a two-pronged approach, thinking of the patient first and then also the resources consumed from the medical center dedicated towards things like one-on-one nursing, disposable single-use medical supplies, so on and so forth, to make sure that we are not increasing transmission within a medical center.
I think that's a really excellent point that you bring up, and I really like that you were thinking of this in a very patient-centric sort of way, where there have been many publications that have outlined it's a very sensitive topic, of course, but it is well appreciated that patients that are on contact precautions and in isolation do receive fewer encounters with their healthcare teams and are more likely to have perhaps adverse events related with their care. And of course, we know, as was already mentioned, that the patients that are essentially being colonized with Candida auris, they're already in the hospital for serious underlying medical conditions. These are very sick patients already. And so we're just essentially making their stay more burdensome for the patient. Yeah. So I really appreciate that your institution is trying to put the patient first and shorten that time in isolation if it isn't needed. If it is needed, then the trade-off for public safety and public health is needed. But if it isn't, then let's get the patients flowing and get them out of those precautions.
And as you suggested earlier too, the vast majority of the results are negative. So not to say that it was unnecessary isolation, because that is an important step in basically keeping everyone safe, but you're right, on the back end of when the results come back, a lot of those patients are not colonized and didn't need it for that reason. And let's hope it stays that way. I know that we're seeing Candida auris rates increase all across the globe, but we like to see more negatives than positives. So.
Yes, definitely. And thank you so much for that distinction. I definitely think that the approach of placing patients on contact precautions and isolation while waiting for that result is the absolute proper way to go about things, because until you get that result, we don't know. And it's important to protect the rest of the vulnerable patients. So I did not mean to suggest that that part was not necessary, but as soon as the faster we can get the result, especially when we expect it to be negative, anytime we can shorten that window, to me, that's kind of the time that we can control. So I think that's the important point. So thank you for that distinction. I think you also, if we could just touch a little bit more on, you mentioned some of the essentially operational impacts at an institutional level. So not kind of underplaying, of course, outside the laboratory, but the impacts to nursing staff and to the clinicians, not only with managing the patient flow. I mean, it can cause backlogs from even being able to accept new inpatients when, private bed space is usually at a premium in any institution. As well as the dedicated staff and PPE and equipment that are required to maintain these sorts of isolation barriers.
Yeah.
And those all come with cost. So not only is there a cost to the patient, but there's a pretty big price tag attached to the institution as well for these isolation days.
Yes, very much so. Yeah. Space and time are the two premiums that we're looking at there. And every day you're spending in isolation, it's very costly to any institution.
Yes, absolutely. And so we've talked now quite a bit about, the impacts to the patient and the organization for this isolation, but can we chat a little bit about now, essentially, where did this request originate? So what was like kind of the impetus for even evaluating alternative methods for bringing perhaps in-house this type of testing?
Yeah.
And who was involved in that decision-making process, if you can share that with us?
I'm smiling because I think it was sort of everyone from every direction all at once was how it sort of came to be. There was no radio chatter at all, and then all of a sudden it was from all directions. So first and foremost, our infection prevention team wanted to do this. Ultimately, they're the ones surveying our patient population and making sure that there's compliance with things like contact precaution, the appropriate patients are getting screened, so on and so forth. But there was also a very vocal component from various clinical departments. I was getting Teams messages, emails, phone calls from people who I'd never interacted with. They're just saying, hey, if you're not working on this already, I really think this is something that you should. And then simultaneously, we're also getting support from our C-suite. At the time, our chief medical officer is a very big proponent of active surveillance, particularly for Candida auris. And so basically, all of those together, we're actually already evaluating various PCR instruments to basically bring other tests in-house. So we were sort of looking at C. auris in-house surveillance testing as an option, depending on what instrument we went with. And all of that just sort of aligned within the same, basically, 1 month period. And it became very clear this is something we cannot wait to do. We need to act now to bring this in-house.
Okay, so certainly these types of decisions, as it seems very clear, multidisciplinary, many different departments are involved and have to have a say, which can certainly add to the complexity of aligning on a particular decision and methodology that would be the ultimate path to follow. It sounds like you had support at a very high level from your CMO, which is, I would probably be a good recommendation if you can start with that. I think
absolutely.
most institutions, I think, are working towards achieving this. So I think that it sounds like you had an excellent start and champion for the rationale to bring this testing in-house.
Yeah.
Can you share a little bit more about some of the key considerations that went into the decision when whether bringing on-site molecular testing would be feasible from the laboratory perspective? Because obviously, when we're now talking about the difference to the impact on lab operations from a send out to now actual hands at the bench testing, that'll obviously impact, your staffing, and it'll impact maybe assessment, as you kind of alluded to. What instrumentation do I have on hand that I could perhaps do this testing? Do I need new instrumentation?
Yeah.
What, how onerous was that, discussion? What were the potential concerns about like testing volume and,
Yeah.
the whole kind of, I think, theory of as soon as you bring testing in-house, volumes tend to increase
Yeah,
magically compared
definitely.
to how, the send-out volumes were. So if you could
Yeah,
maybe
sure.
share with us some of that.
Yeah, the first step in our evaluation was sort of looking at all the data. What are our volumes? What are our current turnaround times with the reference lab? What is our goal turnaround time in-house? What space do we have available? Can we use any of the instruments we already have in the lab to do it? And then what does the timeline look like for going live with this? Because the most pressing matter for us was the timeline, that sort of restricted us to, we were only looking at FDA-cleared options because we could do a simple verification study rather than a full-blown validation of, for example, a lab-developed test. And in the lab that we implemented, we ended up selecting the Liaison MDX. We needed a really small footprint because we are very pressed for space like most labs in the country.
Right.
So we needed to have a very small footprint. And the lab that it went into, we actually have two separate labs. The lab that we ended up placing the instrument in didn't have any previous molecular tests. It was strictly a microscopy based mycology laboratory, and so we needed something that was very approachable for the clinical laboratory scientists working in the lab who are used to doing traditional mycology. We needed a low barrier to entry to say, hey, this is, we're asking you to do this additional test in your already busy workflow. We needed something that's simple to implement, simple to do from the CLS perspective, and has minimal hands-on time. So those were sort of the factors we were considering. We also, a benefit that we saw in the MDX instrument was a extraction independent system. So we didn't want to have to buy a separate instrument for nucleic acid extractions.
Right. So based on all those factors, which sounds like a very comprehensive assessment of everything, that you took everything into account, can you chat just a little bit about how also did your lab think about balancing, this impending new, burden on the lab staff, the impending new additional volume to the lab, with also essentially the urgency of this type of test result that would now be also impacting the laboratory and meeting the needs of your internal stakeholders, essentially, with the expectations of when they would want their results?
Yeah, it was something we sort of did before we even got approval for the instrument. We sort of did hypothetical workflow mapping to say, okay, this is about the anticipated range of volume that we're expecting. So based on that, maybe we could get away with these testing windows or batching on these days. Could we send an additional person over there to set it up and go back to the other lab? So these were all things we were considering. Ultimately, we found an approach that worked for us, I will say, at this time in our medical center. But as you suggested, if test volumes increase, if we change our pre-screening criteria and that increases or decreases our test volume, we basically need to be reflexive and adapt our workflow to that. Right now, because the hands-on time for setting up the test is so minimal, it's actually, and we only run it once a day, it's actually been, the overall impact has not been too disruptive to our workflow, and so far it's going well. Big disclaimer, we just went live about 2 or 3 months ago, so we haven't been running the test for that long, but in those couple of months, it's been a good experience. Yeah.
Okay. Well, one of the benefits of going live with your testing a few months ago is that your implementation should be fresh in your mind. So would you mind kind of walking us through what your implementation looked like from the lab's perspective with this type of test and bringing it in from a send-out?
Yeah, sure. So for implementation, we wanted to start working basically immediately before we even got the instrument. In fact, I think before we even got final approval, got wind that is likely to be approved, we started to work with our lab IT team to say, hey, we're expecting this instrument and we want to eliminate any possible bottlenecks. Can you start working on the interface right now so that when the instrument arrives, when we do the verification study, we click transmit on those results. Can you have it ready so they can go back and forth? So that was a huge part to the implementation. Is our lab, we have a really strong lab IT team. They speak a language that I do not speak and I'm not capable of speaking. So they were a critical stakeholder. Of course, having our CLSs train on the instrument itself, that was a key component, and then the verification itself. Pre-planning before the instrument came, saving specimens that we could do a verification study, so on and so forth. All that was sort of happening at once, so that once we got the instrument, we could hit the ground running and go live very shortly thereafter.
So it sounds like you took a very proactive approach to the implementation of this test. Now, if I could ask, it sounds like involving the IT team, even before you had the instrument on site, was an excellent idea, because I think this is a commonality in all institutions where IT can be seen as a limiting step, sometimes even lagging behind when your verification or validation might be completed. Was this something that you were able to accomplish because of the high priority of the project, or was that something that you could perhaps do because of your proactive planning of this project, or were you able to kind of like get to the top of the list because of the priority?
I think it's a bit of both. By being proactive, I think the lab IT teams at any hospital would generally appreciate not being up against the clock. So just being proactive, get it on their radar early to say, hey, this is coming. But then also, sort of the top-down priority list from the CMO's office, that certainly gets us right to the front.
Helps to expedite things a bit.
Yeah.
Okay, so it does again seem like you took a very proactive approach, and it sounds like things were very streamlined. But looking back, were there any elements or things of your implementation, maybe some challenges that other laboratories should anticipate that perhaps even you built in a proactive way, but just maybe were there any special considerations for this type of validation or verification, or even considering bringing a send out in, like, any specific elements that you would take special care to plan in a proactive way?
Yeah, I think it's lab specific, and it depends on where the lab is based. For us, we were able to gather a sufficient number of positive specimens for our verification study. But depending on your local prevalence, you might not have access to positives. So being proactive, reaching out to other labs, exercising resources to obtain those so you can do a proper verification. That's a key consideration. Also the fact that, even if you're proactive with your lab IT team, there still was a significant amount of interface testing, and it took longer than we anticipated. So basically, being aware that it's not just plug and play as much as anyone would like it to be. There is a significant amount of time and resources that go into actually validating the interface, so on and so forth, not just the wet lab validation. So.
Okay, excellent point to keep in mind. So another element that I'm kind of curious to know about is, once you were able to then implement this on-site molecular testing, if at all, how did the communication change with the infection prevention team now that this was not a test result coming in from a reference lab or a send-out type method, and that your lab was actually producing the result? Did this change at all the way that your lab staff was interacting with the infection prevention team?
Yeah, it did. It didn't change the way that we were interacting with them, but it did change the efficiency in which we were interacting with them. Okay. So you're right. When we were sending to a reference lab, we would get either a fax or a phone call from the reference lab, and then our staff would then call the infection prevention control team. It's not a critical value because this is a surveillance test. It's not like a hemoglobin of 4 or something, but it is an important value. So we pick up the phone when we get those reference lab results and call the IP team so they can make sure that the patient is isolated or released from isolation if it's a negative result. So again, that strips our autonomy on the timeline of when the test was actually resulted to when we get the results, and then could delay the phone call. So now that we do testing in-house, we basically are able to pick up the phone immediately as soon as the result is available.
Cutting out the middleman, so to speak.
Yeah.
You can directly
That makes
get
the whole
those
process
results.
more efficient. Yeah.
Yes, absolutely. So one other question that I wanted to ask you in regards to collaborating with infection prevention teams is, especially when we're talking about some sort like surveillance screening for things like Candida auris, where there are a lot of other stakeholders involved, like infection prevention teams, we often ask, what does infection prevention need? What kind of information do they need to provide? Because they are usually the ones that are developing the protocols and the guidelines for who's getting screened and things like that. But what I want to ask you, since you're a librarian, is what information does the lab need from infection prevention in order to really have the most effective and efficient, screening protocols from the laboratory side of things?
Yeah, I think it's important for the lab to listen and collaborate with infection prevention. What are the bottlenecks on the clinical side? What are the pain points from your perspective? And can we address any of those within the laboratory? And those could come from things like, specimen type. Different reference labs will test different types of specimens, but if you're bringing in an FDA-cleared test that only has one available specimen type, that's a conversation you need to have with your IP team. So I think it's important to have those conversations early and often, and also to create a touch point so that if the IP team changes their screening criteria based on new data, new literature, new guidelines, the lab is the first one to know about that before it even happens, because that could ultimately change your test volumes and workflow and so on and so forth. So it's a really important partnership.
And that's a really good point that you bring up, and something that we certainly anticipate to evolve and change over time are the screening criteria that we have seen change over the years from the CDC. So to kind of summarize, if we kind of take everything together, looking back, what were the biggest lessons learned from bringing this type of Candida auris screening on site, and what advice would you give to other lab directors that are considering moving maybe from send-out testing to an on-site molecular testing method?
Yeah, I think as a lab director, you need to have a pulse on the institution as a whole to sort of, I might get a message here and there about, we'd like to see this in-house, but once you start getting a barrage of messages, that's really something you should start to pay attention to. And then start having those conversations, reach out to people, step outside of your bubble, interact with clinical teams that you've never met before to really understand what is the issue and how can the lab help address that. And I think it's a really excellent opportunity to sort of showcase the lab. The hospital, the health system as a whole had this major problem that we were seeking to address. The laboratory was capable of addressing that by bringing testing in-house. I think as laboratorians, we're often sort of behind the scenes, not front and center, but if you're able to rapidly implement a test that improves everyone's quality of life, including the patients, that sort of brings the laboratory role to the forefront and showcases how important laboratory scientists are to patient care and the healthcare system as a whole.
I could not agree more. I think it's an excellent opportunity to showcase just how important the laboratory is to any sort of healthcare decision. So excellent point there. I love the advocacy for that. And speaking of advocacy, maybe thinking of Candida auris screening at a higher level, just to finish up our I find very enjoyable discussion.
Likewise.
Thank you. So I know that we are here in sunny California, where one of the first areas that really were impacted by Candida auris here in the U.S. So here, screening for Candida auris colonization is very common, and it's been done for years, and there are even very state-specific guidances, as you mentioned, KHAN and things like that. But when you think about Candida auris screening, maybe from an advocacy perspective, what message do you think healthcare leaders need to hear, particularly in facilities and parts of the country where they may not be screening in a proactive way for Candida auris colonization?
Yeah, I think my message would be twofold. One is you don't want to be caught against the ropes. If it's not at your doorstep now, eventually it could be, and you don't want to be playing catch up. So again, I think the whole theme of today is proactive approach works best. So getting ahead of it before you get to that point of, oh my goodness, we're experiencing an outbreak or potentially experiencing an outbreak, and we don't have a way to rapidly identify that. So taking a proactive approach there is really, really quite important. And then secondarily, I would say we need to remain, as a field, we need to remain open to new evidence, new data, suggesting that, for example, we might have guidelines or criteria set right now for screening, but we're learning, even as recently as in the last few months, those might not capture all colonized patients, and so we need to be open to evaluating data and adapting our screening criteria based on the evidence available to us.
Yes, absolutely. It is very enlightening and an interesting field to be in where we're continuing to learn more and more about the organism and the best way to identify colonized patients and the behavior of this fungal pathogen. And I think the more the more screening that gets done, the more that we'll learn about it as well. So
Yeah.
there's many benefits to that type of testing. So perhaps with one final question, we can leave our listeners with. So if our listeners take away one lesson from your experiences with implementing on-site Candida auris screening, what would you want it to be?
Involve everyone you could possibly imagine this result affecting. Involve them before you even get the test. Have the phone conversations, have the Teams Zoom call, Google Meet calls before you get the test. You don't want to be in a scenario where you go live and there's something you didn't think about. It is impacting a clinical team that you didn't necessarily, in a way that you didn't necessarily predict. So having those conversations up front so you have collect all of the data you possibly can so you can make an informed decision before you go live with the test.
Excellent advice, Dr. Osborne. Thank you so much for your time and expertise. I really enjoyed our discussion today.
Thanks for having me.
Okay. With that, I think we will leave our listeners. Thank you so much.
Thanks.